First, I would like to thank the ISHRI organization for inviting us to show our work today. And today I will be uncovering the power of counseling in reducing IVF cancellation rate and in strengthening the patient commitment to the treatment plan. I have nothing to declare. To start off, the ART treatment is very complex and sensitive. So any poor patient understanding can lead to cancellation of the cycle, which can cause emotional and financial stress. According to the Maripir consensus of ISHRI 2021, they reported a 6.3% of cycle cancellation, and also other studies shows that the counseling can really support the psychological aspect. According to Shafagi et al., he found an increase in the self-esteem with 2.4 points after the counseling session following an IVF failure treatment. According to Sulaimani et al., there is a drop of the stress level after a structured counseling session. But today, we would like to shift the focus. Counseling, not only a psychological support, but as a clinical tool to improve the IVF treatment outcome. So our main question is whether the counseling can really reduce the ovarian stimulation cycle cancellation rate, and will it improve the patient adherence to the treatment? We also would like to know what is the cancellation rate and what are the main reasons behind it. And we want to know if the patient characteristics can predict the cycle cancellation, medication error, and the non-adherence behavior. So we did a retrospective cohort study from around 16,500 ovarian stimulation cycle from the period June 2015 to September 2024, including around 6,700 patients. And just to be specific, our data is driven from a Middle Eastern population, so it brings some unique demographics, characterized by advanced age, a low AMH, and a higher BMI. Methods. So we grouped our data into variables and outcome. Under the variables, we have the patient characteristics. We included the basic patient characteristics like AMH, age, and BMI, and the background characteristics, medical insurance coverage, because in the UAE, most of the IVF treatment is fully funded by the government. Marital status, just to distinguish between the couple who are undergoing IVF treatment and single patient who are undergoing fertility preservation. IVF treatment experience, and most importantly, counseling. So let me brief you how we do the counseling session at our clinic. It usually begins in the start of the IVF treatment. The session lasts from 1 to 2 hours. It's not a psychological support only, it's a tailored step-by-step explanation of the whole treatment, starting from the ovarian stimulation, IVF lab, genetics, embryo transfer, and finally the pregnancy testing. We offer a space for the patient to ask questions, to ease her anxiety, and to gain the patient trust. This session is offered for all our patients. However, some choose to decline. Maybe they undergone IVF treatment before, or simply they are overwhelmed. Moving to the cycle disruptions, we track 3 things: ovarian stimulation cycle cancellation, medication error, and patient non-adherence. So what did we find? The cancellation rate was around 11%, driven by 4 main categories. The first and largest group was the IVF-related medical factors with 48%, like low response or hormonal issue, premature ovulation. And the patient personal reason took 42%, what we referred earlier as non-adherence behavior. And medical factors not related to IVF, like illness or COVID-19, and medication error with less than 1%. However, when we looked among all the cycles, both cancelled and completed, we found around 4% of cycle including a medication error, 8% involving patient non-adherence behavior. So we looked at the relationship between the cycle disruptions and the basic characteristics. First, the cancellation. We found out that the 3 factors are significantly associated. So a lower AMH and older age tend to have cancellation of the cycle more, maybe because they are poor responder as well. For the BMI, there is a slight significance where higher BMI tend to have more cancellation, and we found a very similar trend when we looked at the non-adherence behavior. A lower AMH and a higher BMI tend to be less committed to the treatment. However, when we looked at the medication error, we found out that the three factors are not correlated, meaning that there is no specific patient characteristics that lead to more medication error. Here we are looking at the relationship between the cycle disruptions and the background characteristics. For the cancellation rate, when we looked at the counseling, we found a very positive outcome and encouraging outcome actually. We found that the counseled group had less cancellation rate with 9.5 compared to 15.4 to patients who didn't receive counseling. This was the strongest correlation next to the AMH to the cycle cancellation. The first-time IVF patient as well had more cancellation rate, which tells us how it's difficult to navigate the treatment from both sides, the medical team and the patient herself for the first time. When we move to the non-adherence behavior, we found out that the counseling again showing us a very positive impact, where the counseled group had less non-adherence behavior, and again the first-time IVF patient having more non-adherence, showing us the difficulty or the learning curve after the second or the third cycle, IVF cycle. And when we looked at the medication error, we found a very interesting outcome. Counseled group had more medication error than the non-counseled one. While this might feel a little contradictory, but these errors are self-reported. So we believe that the counseled group are more aware of the potential failure of the treatment. So they tend to tell us whenever an error happens, allowing us to have a quicker intervention and adjusting the upcoming doses. And this helps us to reach to a less than 1% cancellation due to medication error. We found as well that the insured patient had more medication error, maybe they have less financial pressure. Again, and here the married group and the unmarried group. The unmarried group had more medication error. We believe maybe they have less urgency for pregnancy comparing to unmarried women who are actively seeking pregnancy. So to wrap up everything, AMH, counseling, and age were the strongest predictor to cycle cancellation. We found a reduction in the non-adherence with the counseling and the IVF experience. Medication error happened more often among the insured and the fertility preservation patients, and thanks to counseling, the reporting was better. But our study, of course, has its own limitation. It's a retrospective design and driven from a very specific population, the Middle Eastern population. However, the takeaway message is crystal clear. Counseling should always be an integral part of the IVF treatment, not only as a psychological or emotional support, but as to make the patient informed throughout the whole process. I would like to thank the whole ART fertility team for their incredible work. A special thanks to Dr. Raquel, Susan, Dr. Barbara, and Professor Fatimi for their guidance and support throughout the whole process. Thank you all.